Hello, everyone. My name is Kimberly Hilfrank. I am a certified genetic counselor who works in the inherited GI cancer space at Columbia University Medical Center. And I am also the vice chair of the communications committee for CGA-IGC. And in honor of Pancreatic Cancer Awareness Month, I have with me Dr. Fay Kastrinos, who is the director of the Gastrointestinal Genetic Risk Assessment and Prevention Program, as well as director of the Muzzy Mirza Pancreatic Cancer Prevention and Genetics Program at Columbia University Medical Center. And she is here today to talk to me a little bit about a recent paper that was published in JAMA Oncology in July 2024, entitled Pancreatic Cancer Surveillance and Survival of High-Risk Individuals, a paper on which she was a collaborator and co-author. So, Dr. Kastrinos, thanks for making the time to talk with me a little bit today.
Oh, thank you for having Kimberly. We're really committed to this effort for early detection of our high-risk patients at risk for pancreatic cancer. So thank you for the opportunity to speak a little more about our participation, what the work has been done through the CAPS consortium.
Speaking of the CAPS consortium, my first question for you is, could you explain a bit about the CAPS consortium and what the goal of CAPS is?
Sure. CAP stands for the Cancer of the Pancreas Screening Program, which it was initiated in the late 1990s, 1998 specifically, an effort spearheaded by the Johns Hopkins group to provide screening to high-risk individuals for pancreatic cancer. So those individuals that had an increased risk based on their family history. So having a high burden of pancreatic cancer in their families. And the goal was to take these individuals and to offer them some sort of screening for the pancreas, which relied predominantly on imaging. So when the study started late in the 1990s, it really was as a pilot, a small group of high-risk individuals, about 38. It subsequently doubled, and it was a prospective study through CAPS-2. And then it wasn't until CAPS-3 where it became a multi-center study whose goal was to compare three imaging modalities at that time: CT scan, EUS, and MRI, in providing screening of the pancreas. And at that time, up to 225 high-risk individuals, growing further to a larger multi-center study with 8 sites, of which the results of this study have really provide us with these most recent results.
And so you spoke a little bit about individuals who could enroll in CAPS and were considered high risk. How do you define high risk for pancreatic cancer?
Sure. So, in the general population, screening for the pancreas is not recommended because it's not a very highly prevalent disease. But when you take the general population and you enrich them with individuals who are at high risk, meaning having a higher risk than in the general population, predominantly in this cohort of highest risk because they might have a genetic predisposition or, again, that high familial burden of pancreatic cancer, you have a justification to offer them screening. So early on, CAPS predominantly focused on individuals who were from familial pancreatic cancer kindreds. So that basically means that the person screened had a first-degree relative with pancreatic cancer, and that family had a pair also of affected first-degree relatives with pancreatic cancer. So you had 2 or more people in the family with pancreatic cancer. That's considered a high risk because the relative risk of pancreatic cancer is high. And then with more genetic testing and better identifying families at high risk, we also included individuals who had a genetic predisposition. So individuals who had pathogenic variants in genes of which pancreatic cancer is associated with their syndrome. And those genes include BRCA1 and 2, ATM, PALB2, CDKN2A, as well as STK11, which is associated with Peutz-Jeghers. So those individuals comprised the high-risk individuals that we offered surveillance to and then followed them prospectively over time with continued screening.
Okay. And speaking of screening, currently, how is pancreatic cancer surveillance performed? Through what types of imaging?
Sure. So we rely on MRI and endoscopic ultrasound. So from the CAPS-3 data, we found out that CT scan was not as sensitive as the other two modalities. MRI in EUS is picking up small lesions. So in 2014, in the CAPS consortium, we relied on using both endoscopic ultrasound and MRI. The methods of which screening were performed early in the CAPS, or earlier, I should say, in the CAPS consortium, were that both tests were offered initially. And then with subsequent years, it would be that one modality was offered and then alternating with the other. So an MRI and endoscopic ultrasound alternating one year to the next was very commonplace in how to screen individuals, and you were able to have both tests. We're finding out more and more, however, that endoscopic ultrasound might be even more sensitive in detecting smaller lesions than MRI, and that there are potentially higher miss rates amongst radiologists for small lesions on MRI. So we do rely on endoscopic ultrasound very heavily, as well as MRI in the CAPS consortium.
Okay. Got it. Interesting. Interesting to hear how the preference for imaging has changed over time and figuring out which modalities are more sensitive and might be the best fit for our high-risk patients.
And Kim, it's important also because results of these studies help guide other practices, other institutions, and what they may offer. And across the country, there might be some resource restrictions. So if you don't have access to high quality endoscopic ultrasound, the way we're accustomed in these consortia and research protocols, it is good to know what an alternative, a viable alternative may be, such as radiographic imaging, in this case, MRI, MRCP.
Yeah, that's a good point. EUS is sometimes not super accessible everywhere, given, the interventional gastroenterologist who has to perform it. So, as you said, good to know about other modalities for other high-risk patients across the country.
That's right.
And thinking about our high-risk patients and thinking about the data that was presented in this recent article, when compared to the US national data from SEER, SEER, how did the study participants who were undergoing high-risk surveillance fare?
The take home is that once you are enrolled in a surveillance protocol, that the benefit is there in detecting pancreatic cancer early and higher survival rates. So the take home in 5-year overall survival, the rate was 50% in high-risk individuals undergoing, surveillance and imaging versus 9% in those that were not, those in the general population who developed pancreatic cancer. So that's the big take home. They looked, so overall survival also ranged around 62 months for high-risk individuals who had undergone surveillance compared to only about 8 months. So other things that they looked at, so that's the big take-home message, right? That survival is going to be really impacted once you detect these cancers early. The data showed a significant shift in tumor stage. So you had lower stages of both stage 1 and 2 cancers amongst high-risk individuals on the order of, over 70%, compared to much lower numbers, around 35%, near half, in the general population. And again, overall survival is the take-home message with, lower mortality related to pancreatic cancer amongst those high-risk individuals.
Yeah, that's really exciting. And
Really.
yeah, and I know a lot of people in the like high risk community were excited when this paper came out and what it might mean for them moving forward. Which kind of brings me to my last question. So, thinking about this data, what do you think it might mean for our high risk patients in the future in terms of their surveillance and what, yeah, pancreatic cancer outcomes might look like for them?
Yeah. So, given the results of this study, I think our high-risk individuals who are very committed
Mhm.
to their surveillance should feel encouraged by these results and, continue to participate in such intensive protocols. I think when able, if they could seek out research programs as well that offer this screening, because there's still a lot of work that needs to get done,
Right.
right? There are other modalities that might be viable, screening alternatives, possibly non-invasive tests, blood-based tests. And there is also, from a research perspective, the opportunity for us to study and validate some, serum-based biomarkers, whether looking at proteins or circulating tumor DNA, that it might offer an alternative or a potential test that we may integrate into our current screening strategies. Now, something that I feel really important also from these results is a lot of individuals need to get screened in order
Yeah.
to identify pancreatic cancer. So perhaps some study in looking at our cohorts to even determine better risk stratification amongst our high risk individuals would be
Mm.
helpful as well. Who are our highest of high risk individuals, and how do we offer and maybe personalize their options related to surveillance in the future. But I think overall, these results really highlight our continued efforts and the continued need to develop, diagnostic tests that are going to be more sensitive, but also how best to standardize these screening protocols so they could be used through the consortia, but in the greater good through practice and other institutions, nationwide and beyond.
Yeah. Sounds like a lot has happened. We've come a long way since the first iteration of CAPS was started in the 1990s, but at the same time, we also have a lot of work to do. So I'm eager to see where pancreatic cancer research takes us in the future. And I want to thank you again for taking the time to share your expertise with me.
Thank you so much, Kim, and thank you for giving us the opportunity to highlight this work.